Welcome. Thank you for attending today's FASD learning series. Our theme for this year is presentation. How about prevention? The theme for this year's learning series is prevention. We opened the season this fall with a presentation by Nancy Poole, who challenged us to think about what we know about prevention and whether we're actually doing it. Today, Dr. Sharon Britnell will discuss lessons learned from her research regarding transitioning adults with an FASD from correctional settings to community settings. Before I introduce Dr. Britnell, there are a few housekeeping tips. You can ask questions during the presentation by using the question and answer module on the right-hand side of your screen. A session facilitator is monitoring the questions and will pose them at suitable times during the presentation. If we aren't able to answer all your questions during the live presentation, we will answer them via email after the session is over. It is important that you include your email address when you ask a question, otherwise we will have no way to send you an answer. The presenter's contact information will be at the back of her presentation, her PowerPoint, and is on the last page in your handouts. In order to receive your certificate of attendance, you must have signed in your room after 8:50 a.m. Evaluations for this session will be emailed to you after the session. Please fill them out and return them. We really do rely on your feedback to continually improve what we do and how we do it. Today's presentation and handouts will be posted for viewing and downloading on the CMC website. I'm going to give you that website address now. FASD-cmc.alberta.ca. If you experience any technical issues, please email Clayton at, I'm going to give you his, at support@cmgcanada.ca. The email address again is support@cmgcanada, all one word, .ca. Also, please let your local tech support know, as the problem may originate on your end. I think we've covered that for housekeeping, and of course those in the room, if you have questions, just draw them to the attention of Jess. As Alberta advances with the FASD 10-year strategic plan, education and training continue to play a key role. This is our 5th year of offering sessions and our 2nd year of delivering the material as webinars. As always, all sessions are taped and made available on the CMC website at that address I provided earlier. We are pleased with the ongoing interest and attendance in this initiative. We appreciate the work of CASA, Child, Adolescent and Family Mental Health, and the Alberta Centre for Child, Family and Community Research in making this initiative such a success. Now I have the pleasure of introducing Dr. Sharon Britnell. Sorry, my mind just goes to another pronunciation. Sharon is a professor in the Department of Occupational Therapy at the University of Alberta. Her career has been dedicated to the development of occupational therapy services, focusing on mental health. Her clinical and research activity has focused on understanding the impact of illness and injury, both mental and physical, on a person's engagement in productive activity at home and in the workplace. Sharon is a past president of the Canadian Association of Occupational Therapists, has served as an advisor to government and programs both at home internationally, and is currently the president of the World Federation of Occupational Therapists. Please join me in welcoming Dr. Britnell. Thanks. Sorry about that.
Thank you very much. I want to say that my name has been a sort of a test over the years, and there's many variations of it. I'm very pleased to be with you this morning and to have been invited to participate in the series. I'm very dedicated to the challenges and that we have in discovering how we can best serve individuals with fetal alcohol spectrum disorder. But I am particularly interested in adults, as I'm not the child lady. So I want you, just one logistic for me. I have built in a break at the end of the first part. You'll see that on your handouts. But during the time, if anyone has a question, can they interrupt, or shall we wait at the end? So you will see there's a lot of slides with pictures, and I'll move through those very quickly. But I think that we need to use visuals more. It's much easier at times to understand a lot of information when you've got a picture to see it. So hence I've used some of the reporting of the project in Fort Saskatchewan for this presentation, as well as I'm drawing on not only the results of the research, but I am also involved in the Alexis Justice Project, where up to date we've seen about another 32 adults. So all of that comes together in this presentation. So once again, I hope that you will find it informative. I am going to try and focus on the prevention of people being incarcerated and understanding all of the elements that they need in their life. So let's begin. So the learning session objectives, you already have those, and I've set the presentation up to follow those, although every now and then I take a little poetic license. When you're passionate about things, you tend to go off track, so I hope you'll indulge my passion. So this is the way it's set up. Fetal alcohol spectrum disorder is a disability, and I'm drawing on my experience with the World Health Organization, where I'm going next week, actually, to meetings in Geneva. I'm going to give you the profiles of the adult males who were in the project, 3C, Corrections to Community Connections, which was funded by the Tri-Ministries group at that time. The community services that they access, so it gives you a data-based portrayal of their needs and what we found out about it. And I'll also share with you some of the things we didn't find out that maybe we had hoped to find out. And the last one is really not an academic exercise, but it's coming from you. And we'll get into what are the things that we need to think about that we would like to see in place to provide consistent and accessible service for this very difficult group of individuals to sometimes come into services. All right. I love this quote. I've used it a couple times, and you know, the time has come, the walrus said, to talk of many things, of shoes and ships, and sealing wax, and cabbages and kings. And so our looking glass now is to look at fetal alcohol spectrum disorder as it affects male adults. And it's really a context that we must put into a bigger framework to recognize that these individuals do have a disability. So I'm framing this within the larger order of disability as it relates to recognizing that there is permanent brain impairments. That sounds like a negative thing. We're so schooled to think of strengths. But if we don't continue to recognize that there are real deficits here, these are not just behaviors, it's not psychological, it can sometimes put us on the wrong track when we're trying to assist people. So, from a global perspective, the World Health Organization put out a report in 2011. This is a monumental document because the WHO World Report usually doesn't deal with something as focused as disability. It's usually on world health or economics, and this time it was with the World Bank. And what they discovered is that 1.5 billion people have a disability. And when I speak about a disability as an occupational therapist, I think about it as people who have an activity limitation. And that it can be a result of a processing impairment or brain function, or it can be a result of motor or activity. And to raise the importance of this issue, there's a UN Convention on the Rights of Persons with Disability. And that is driving a new agenda for disability, which will influence not only the World Health Organization, but it's member states. And of course, Canada is a member state. And as a member state, it then has its provinces. So this is far-reaching. Some of you may be familiar with the International Classifications of Function, it's a diagram you may see frequently. So you have the condition, you have the body impairments here, which is the structural things. We have the activity limitations, which in the old way was called disability. And prior to the revisions, we used to call this participation element handicap. So we still have that in our language. We talk about people with handicap. But in the new world, it's really referring to the impact of that, and that's people's participation in all their life situations. So the major other changes in this framework, it has an environmental consideration and then the personal factors. So you can think about this as all of us in the support areas. And here you might think about these as the social determinants of health. What are the background things? So as an occupational therapist, I work in an area that looks at the person, the environment, and the, what is the other part of that, Sharon? Or the occupation or the activity. Okay, so a very famous diagram that you might have seen, and it is in the rehabilitation conceptual framework of the province. So the social issues. When we speak about the social issues, what do we learn? And there's a list here of the many, many kinds of challenges, problems, whichever word you want, that contribute to impacting on people and what they do. And that includes us. So the social determinants of health is another major document, and Alberta does have a document as well that looks at this. And this is what we bring to our background and what we are involved in. So working conditions, living conditions, our education, our family relationships. Poverty is a key element with the social determinant of health. And why is it called that? It's because they impact on health. The definition of health is an expanded one. So it's not just the condition itself, but it's all these environmental factors that contribute to us. And many of those are now called epigenetic things. So simply stated, your socioeconomic status, your gender, your age, your background. And unfortunately, we often find that people with severe disabilities, often those that find themselves in services, are those that we call marginalized or disadvantaged. So they're usually coming from backgrounds where there has maybe been elements of poverty, money is tight, they may reflect a particular ethnic group, and it may be geographically considered. And all of these fit on the profile of the people that I've seen, and I'm sure the ones that you are. And they're partially considered in the Canadian Diagnostic Guidelines. So we are well informed here with the Canadian guidelines and in Alberta. This diagram is one of those nice pictures that I like. I think it's much more powerful. And it's one you might want to take out of the presentation and to remind yourself that when you're working with people, you have to explore a little more than just what they're talking about or the problem you're dealing with. There may be some other major things. Without stability, there's no mobility as an occupational therapist. No stable housing, very hard to program. So very important considerations. And we know in some of our other populations how it is more powerful environmentally than others. Function issues impacting community life. So these are the types of issues that we all hear about: fetal alcohol spectrum disordered presenting problems, antisocial and impulsive behavior, susceptible external pressure. But some of the other things that we have to particularly know about is they don't always understand the message that you're trying to get through. And this has to do with language, both expressive, their ability to say what they're thinking, and then their receptive language. And I know you've had a lot of of presentations on this, but I think you can't not repeat it, that even though when there's a nice flow of language and you've got a wonderful history, you have to keep reminding yourself that this may not be an accurate picture of what they are understanding or even how they are able to organize their thinking. The things that we find: drug use in preteens, compounds impairments, substance abuse histories, all of the thought of in some cases as secondary or disabilities. So a person with FAS, and if you take nothing away from today, this is the message I really want you to have. That what we deal with is a very complex brain. So we know about the fetal alcohol exposure. It's the frontal lobes. These are hot, whoops, sorry. Your mouse is sensitive. Does this one work?
The mouse?
This one. I was using, whoops.
There you go.
Sorry about that. I've lost the plot. Is it aggressive? We were talking about my iPhone, and the term was it was aggressive. So these areas in the brain is the frontal lobes, where the executive functioning is. The cerebellum that we never thought about before is this bit in the back of your head. And I know when I was learning anatomy, it was primarily about balance. But it's much more involved in much more diffuse activities. And the one you don't see is that little band of tissue that connects the right brain to the left, the corpus callosum. So that's what we understand that happens in utero. But then we're finding there is a whole group, not all, who start abusing alcohol early in the teen years, when the brain is still developing from the age 12 to 22. So a second assault is occurring. And then, if we look at their histories, it's not uncommon, again, not with all, but to have another traumatic head injury, a car accident, a fight or something. So you have 3 possible layers of assault. So that's why we have to think carefully when we're talking about some of the strategies out there that have been developed to work with people with just psychological problems. We are encouraged by neuroscience and brain plasticity, but that's probably for a younger brain. Anyway, enough of the neuro sciences behind it, but we do have to understand this because we give our message with assumptions. All right, so I'm going to move a little quicker now. So these are the profiles of the participants in Corrections to Community Connections, which is a research program that was conducted out of the Fort Saskatchewan Correctional Site. And it was one of the government's objectives, of course, in the strategy for us to understand and to look at the population in corrections and to see, is there people with FAS? And without getting into that research, this is the results. So we also had, though, a community reintegration part of, if we did the testing, we have a responsibility, a moral responsibility, to assist these people. Research nowadays isn't just to use the people and then say thank you, and then the researchers go out there and put that data somewhere else. It must be useful in feedback into the system, and this is what we're doing today. So what can we do to do a better job in helping them bridge to the community, what we're going to talk about today, and trying to understand what they were using in the community. Because adults, we have very little information with. So there's a growing body of knowledge about some of the conducts and relationships of people in prison or in jails and how to prevent that. There isn't very much. There's a little bit coming out now, specifically with the fetal alcohol spectrum disordered population. I have graduate students doing reviews on this, and you know, we're always hunting in the literature. And so this information that we have here that I have to get into journal format is really somewhat of a unique profile. So this is who they were. And I think first and foremost, they were people. And they had many roles in their lives. They all really, in our group, for those who had children, all wanted to be better parents. So we mustn't forget that circle, that social network that goes around it. And sometimes that can be really an incentive. My voice is cracking way, I'm emotional, but I'm also losing my voice. So this isn't all emotion. So you can see the breakdown on the age. It is pretty widespread. The ethnicity, which is always the issue because we know there's a disproportionate number of people from First Nations. So we had 37 Caucasian, 37%, and 57 who identified themselves as Aboriginal. At their grade levels, we had people who had a couple of years of post-secondary education. Again, the mythology that the spectrum doesn't always have the ability to go on to school. We know that isn't true, but again, data-driven. The real, again, confirming was the normal range of weight and the normal range of height. Head injuries. Now, this is from my last here. In this group, 51% of them reported that they had had a blow on the head and had lost consciousness. Now, of course, there's some range in their memories, but that, again, reinforces the fact that this is not just a result of possibly the birth assault of alcohol. The other thing that was important was the psychiatric. We did a psychiatric workup. At that time, it was the DSM-4R. Now we have a new rating. But I think here, so 94% had substance abuse, which means you can throw that away. You can consider for this group that all of them had a substance abuse. But this is the one. 73% of them had some form of psychiatric phenomena on what we call axis 1. So they had anxiety. They had mood disorders or depression. And you had, of course, the attention deficit disorders. And so we were really able to say that this is a very important part. Is it a primary or is it a secondary? And there's another research question. Personality disorders. So I'm going to just go through. This no longer is presented in the new form of the Diagnostic and Statistical Manual, but they had health conditions. And the stressors in their life were significant, as were the events that led up to the time that they were incarcerated. So I want to now share a tool that we use, which is the Independent Living Scale. I was looking for something that was developed for people that had some form of cognitive impairment. This was originally developed to determine the legal competencies of elders, older people. So again, look at the categories here. Memory, managing money, managing home and transport, health and safety, social adjustment. The questions are all practical. And I work very closely with Dr. Monty Nelson, who does the neuropsych testing. And I can find in my testing memory functions that Monty may find that they've got memory impairment. But the nature of what we call here is in situ. It's very practical events. So they can bring in events around them to shore up these functions. So I'm going to jump to this one, which gives you the two major areas where we found substantive was money management. That has to do with counting change. Do you know about banking? Which probably is obsolete now, but everybody has a debit card. Can you do a quick calculation? If you gave somebody $5 and you had to pay for the bread, how much change would you have? All of those very practical things. Numeracy impairment, as we think, handling numbers and money. Social adjustment is really an interesting area. It's the weakest of the testing because it only has 7 items. It talks about a social network, but it taps into mood. So anybody that has any mood disorders will get a low rating here. And again, it reinforces the testings. So we are able with this tool to get a very practical profile of people. So the results of our total, now you have to think about a line here because this is the total score. But you can see here, these are our first group of connectors. What we did to try and make sense, we looked at the people that came back into the system quicker than those that stayed out. So it was a way for us to do some comparisons. What kept people out? What brought people back in? And it's probably, when I changed the colors on the slides, it lost a little bit of its dimension. But I think the next ones will give us a little more. This is the non-connectors. What I want to show you here is they're grouped at a higher, 60 is the highest score that they can get in those. And they are grouped up at the top. Not all, but most. So their memory score, again, you can see the same pattern. Higher scores in the non-connectors. And you can see there were some that had very low functioning. Money management, again, higher connectors, a little more grouping here. Some questions here have to do with banking and when do you file your tax return. So if you first particularly have not filed any, you might not know April the 30th. Again, this is the same pattern, and you can go through and look at these things. What you're seeing is higher groupings for those people that didn't connect. Home and safety, what happens if the lights go out and your TV goes out? What would you do? If it's too hot or it's too cold, what would you do? So all of these things are very much the kinds of life skills that we need. So I'm going to go pass through. The problem solving is a summative score, and it is the one score that is comparable or to neuropsych testing. And anyone with a low problem scoring score came back in quickly. This is the sensitive measure. It's a composite of the whole scale. General information, there wasn't anything discriminating there. So again, we used a tool to come up with the profiling, and this is being built into our work in the other areas. Okay, I'm going to look at, if you look at low, high, moderate, this is to do with functioning. And you can see where the groupings are. We had really 60% almost of our connectors are in the low scale, while only 27 of the connectors. Eventually, over time, most high percentage did come in, but our higher functioning people were able to stay out. So what does it tell us? Here's a list: interests and vocational explorations, as well as what we need for addiction services, social skills, and socializing. I'm using the word social network now rather than social support, because when we work with people, we're a social support. What it seems to be more important with this group is their network. Their network can be positive and it can be negative. Who they hang out with, who's there when they need to call someone, who is always there to give them that assist. So then social network is an idea that we have to think about. And so some of the other areas. Informs the degree of community supports. This particular group would need a lot of community supports. As you saw, those people in the middle ranges there, they need, and by that, the interesting dilemma is when we say community support and independence, what are we talking about? They're all living by themselves, many of them. They are taking the bus and moving around. But that support part, the dependence or independence, has to do with meeting the everyday challenges of what we expect: being on time, going to your appointments, taking your medication, being able to follow a regime. That element of independence is what we're really talking about. So the types of supervision, all of that leveling gives us some information on how to make those decisions. Urban living skills, one of the recommendations, and I see it creeping out there, so somebody maybe is reading the report. Not life skills, urban living skills. How to survive well in the city. Okay, it doesn't tell us much about the networks. We did in our asking interviews about who did they call and who did they see. And that's an area that we really need to put more focus on. So we know that they impact, because with the stories that we hear, we frequently hear that someone with FASD happens to be with a group of people who get into trouble, and they're along with them. They may not have done anything actively, they may not have been the perpetrator. In some cases they are. We had a breakdown too of the kinds of charges. The majority of them are in jail, you won't be surprised, for breaches. They didn't follow through on the conditions. So if they got probation, if they were supposed to be in at night and not drink, they didn't show up, that's because those are the areas that they have the most difficulty with. They probably didn't understand the conditions in the first place. So very, very important. Okay, this is my thesis. We presented this when there was the consensus, the first consensus, that these services and considerations need to start early on. We don't want people in prisons or jails, but they are there. So if they are there, we have to intervene or start intervening in the system. And of course, some of these other projects, like in mental health, is to look at strategies that might look like diversion. But we have to know who has FASD first. Okay, so primary needs first. Social network determination. Housing is a critical one, but who's out there to support them when you're not on duty is really a major, major consideration. That's a big risk factor. Knowing about what's going on in your activities in your communities, it isn't just about formal programs. One of the strategies as an OT is we build a daily routine with a timetable, and we get into that. So knowing about programs that are open to the public and trying to find the niche. Personal contacts and relationships, we often in looking to support look to families. They may not be the supporting mechanism in this group, because many of the people that we saw were already distanced from family members. And so that may not be your first source. The other one is about their health status. Trying to find out when was the last time they had a medical, because when they go into corrections, it's a very short screening and people are not forthcoming about what's the trouble. But you'll see it in the other data. You need to have a home, and we know that housing is a major problem, and we also know that our kinds of clients create even more difficulties in housing, so I'm not going to spend a lot of times on that. And contact numbers, more than just one reliable source. Everyone seems to have a cell phone. Unfortunately, often they are determined by cards, and they also are a target for theft. Some of our people have talked about being attacked for their cell phones. So although we talk about technology and it being used, it also can be an issue. And ID, having proper ID, as you know, to access financial supports. Their understanding of money and some of the instrumental processing skills. Taking them shopping, teaching them to make change and so on. They are the best benefiters of demonstration. Not just instruction. Occasionally we hear people talking about cognitive behavioral approaches, certainly not with the more severely impacted individuals. and you need to have reasonable cognitive processing to be able to use those strategies. So, formal community support through case managers and community workers. And all of these lists are things that we tried to think about in making it work. What were the risks? What could we put in place? We were able to have in the project community workers. Originally it was to be part of the project, and then as the project started, it was that became a community partners function, and Bosco Homes was the community partner in this project. So they really looked after the community interactions and the whole community connecting, if you want to call about that. In the corrections, we did a program that we called Mind, Body, and Spirit, which was very similar to a program we ran for a short period of time with women at the fort called 2C, and we presented on that. So we had a chance to explore who were they, what their identities, what did they want in life. The literature and our understanding, people have to be connected to goals. So who were they? The fathers, the brothers, the parents. That's where the role functions came in. And also a little bit about good hygiene, and this was highly repetitious internally. So at this point, I seem to have missed some slides here. Did I? Excuse me while I just go back at my paper copy. No, we're good. So I'd like to take any questions that might come up from this and just give you a chance to stand up and stretch. We're making better time than I thought. Are there any questions from the site? No? Are you good? Yes.
Dr. Britnell, I'm wondering. Dr. Britnell, I'm wondering what you would say was the most surprising finding of your study.
The range, I think it was. You know, even though we know it's a spectrum disorder, we get the information about a particular profile, a small body structure, the facial features, and the impulsivity, and some of the maybe the lack of ability to sustain performance. And what we got was overall normal development. So on the brain score, 1. I'm sorry, on the development score, they got a 1. They were well within the normal range, and I was expecting a greater spread. Facial features were primarily absent. Now, subsequent to that, we are now finding that is the case, because there was, do they grow out of them? Do they change? Or when you're an adult, are they not as evident? And we are finding now with other research that there are some people who have FASD, but they don't have the characteristic facial features. So we can't use that as a detector. Yes, we can, but it's going to leave a lot of people out. And the profile of the people who really were being productive in the community. They were people, as I said, post-secondary. They were driving heavy equipment. And what we saw there was very strong, usually marital relations, common law or other, that social network. So the range, I think, was a surprise, because I wouldn't have expected the higher level people in jail. But the impulsivity and, of course, the prevalence, the pervasiveness of the substance abuse. One of our recommendations on this report is if they are incarcerated, and the average length of stay for these was about 233 days, we should be running addictions programs in the corrections. And we often have short courses, which are wonderful to attend. They're not staying with this population. So from that big profile. Yeah.
Do you have any idea of what it would cost to adequately support someone in order to prevent a breach once they're once they're out of prison, as compared to them being charged again, brought back into the system?
Well, we calculated in the report what it was it cost about a 1.2 million for this particular group to be in the correction center, and that was using a very cheap, no frills number that we got from Solgen, and 1.2 million could have done a lot of community programming. I'm sorry, my brain's going a little bit. I've had a couple of late nights. The Institute of Health Economics is doing a lot of calculations on that. And it's kind of hard to tease out direct costs, but I think it's very fair to say that we could do a much better job in the community with money, and that's the reason why these justice projects are coming in. If we can divert them, I mean, that's not even costing just getting them into the system or their communications with the clerks and going into the remand. And there's a lot of peripheral things with justice, let alone corrections. So I think there's a real awareness that if we can identify and triage or divert, we could use some of the savings, a lot of these savings, which is the message we're hearing across health, in doing things that will support and keep I'm going to generalize, and please, I'm not meaning to be discriminating, but when I'm looking at the people that we're seeing now and this population, they are not competitively employable. And I'm one of the people that have taken a very negative sense, even with PDD programs, when we were going to make employment programs. I am the guardian for a dependent adult, and as an OT, this is my work. It's not work. It's volunteerism. It is productivity, that they are contributing to society and the things we know. But when you say work, the usual processing that is a job for which you get paid. And the pattern with this group is many can get a job, but if you really look into the history, they do not sustain employment. They're really good at getting jobs, and they may even be good workers. But on week 3, they're going to decide they're not coming to work. Now, maybe if we had a support mechanism, that would change, but that's the pattern. They get the job for one reason. They can't either do the job. Many of our people can't even work at McDonald's. If you can't make change, if you can't handle the sequencing of placing the orders, you can't work. You could work in some environments, and this is a whole different discussion, but I think that's really my thesis. Productivity roles is what we're talking about, what we would consider in the volunteer, supported, mentoring, working in a model. There's opportunities for employment, particularly in some of the northern areas. One fellow lately said, if it's yellow, I can drive it. And it's true. And he was one of the people that had very higher level functioning skills. And as long as he wasn't drinking, he could sustain the program. So that external brain we hear about is much more complex or harder to put in place for adults. They're free, autonomous beings. So I think if we can do a better job early on in detecting, and some of our participants were determined in school but never formally assessed. So that's why there's a lot of work with screening tools, because the formal assessment is really quite expensive and time-consuming. So I really do believe that we're getting closer to being able to develop a profile of people at risk, even if we can't, but our system says you need a diagnosis. So those are policy types of issues. And there is, I have an idea, and I'll show you, I'm talking about virtual communities where we can support people. Any other questions? Thank you. That's really important. Okay, well, if I'm no off-site, you can get up and move around. take you to the next part, which is what's working and what's not. So a few references. Have you got these strung? Number 2? Clayton?
Yep.
Is this the number 2 coming up? Or do I go out of this?
You have to get out of that one and then,
Go out of that one, okay.
and then start that one.
That's, wait a minute, where's the next one? The lighting here for me. Sorry. A little logistical. Part 2. Oh.
That's the one.
That's the one. Lots of pictures, so it takes time. Thank you. I'm sorry, Clayton, I made a bad choice on the graphic coloring. But after I discovered it, you know what? It was too late and I was too tired to change it. What's working, what's not. So now these are the results, and I'll feed into that some of the other experiences, because unfortunately our social data, our community integration, was not as rich as we would have liked for a number of reasons. As I said, 65% of the participants connected with justice within 6 months. So there's a big cost factor. And again, it probably was a breach. And I'm sure people understand a breach is where they didn't follow the rules. They didn't commit another crime, another event. What happened is they didn't show up for a court date, and so they get more time. So, you know, from a lay person perspective, you think, that doesn't make a lot of sense. But that's exactly the way the system goes. An increase of 25% over 3 months. So we took benchmarks at 3 months, 6 months after they were released from the initial charges that we saw them for. So this is the high recidivism, or recycling, as the words are tight right now. Important part, 81% of almost 2/3 of them had juvenile records. So again, they're the lower functioning people. They're the ones that got into trouble at an early age. And if you remember that a large proportion of them are also abusing alcohol on top of their primary disability, I mean, it's a very lethal cocktail. No associations between corrections, offenses against persons and charges. We were looking, is there more severity of changes? They had a range of charge. There were some with assault. 94% of the participants abused substance. So you can just consider in this group that they are all pretty well substance abusers of one kind, alcohol or marijuana primarily. There were some heavy coke users as well. Okay, so those clients, I think, are often the ones who come into social services or community supports because they can't do it on their own. If you think about the higher level functioning people, they're the ones with a good social network and jobs, and they just got, some of them were driving while impaired, multiple charges, and so end up with time. And there were 1 or 2 who happened to be stopped, and then they found out they had outstanding warrants from years before, which is typical too. So I think we can use this profile. It's not generalizable, of course, it just belongs to this group, but the lessons learned, there will be similar patterns if you're having challenges. So I think we need to keep the range in mind, but you also have to remember that the fact that the ability to understand what you're saying and what you want them to do, we like to use notebooks and have people come back and tell us what they're doing. That's not a very good strategy here. So the transition advocates is what we call the community workers. And here is where the breakdown was, the time that they spent initially with 46 of the people. 3 people said they didn't want to participate in it. 7% in connecting with houses, so it means that probably some of them went back to families, but we know they were couch surfing because we would get phone calls after. 9%, this is the identification, they had no ID. Some of them had other legal issues to deal with. Medical in here, mental health referrals, and that was interesting. There was only 3% connected with mental health, given the large number of the individuals who identified. They are not good historians. The people interviewing have to be sensitive to elements of depression and anxiety. I think that anxiety underneath often is interpreted as some of their negative behaviors. So contact with professionals here, just the addictions, connections, coaching and mentoring. That might have been for a placement somewhere where they have, we tried to connect with the spiritual dimension. Originally we wanted to have an elder as part of the team because we were anticipating a large group of First Nations or Aboriginal individuals. But then, you know, there's such diversity in those groups. What we chose to do is to connect them with a resource rather than have someone as a member of the team. Community resources is probably the high one here, trying to get some, and look at financial. They needed SFI, or are we still calling it SFI? Or AISH. So we know of AISH, you've got to have an assessment that says not competitively employable. And I'll speak a little bit more about that. After employment areas, there were no direct employments. The focus, 6 months after, so was there any progressions? The family-related issue would be phone calls, probably, from those family members still in. Basic needs are all of those personal supports of housing and connecting them with the resources, clothing, finding we had a kit that everybody got when they left, some basic things. Personal supports, 20% here. So that would include part of the TA's contacts with them. Health issues, 17%. This is growing here. So those individuals were probably connected with a health unit, or if there was a family physician back in. It's interesting in the system, you know, with primary care coming now, we might be able to do a better job. We didn't have women in this room, but with the 2C, C2 project, so we were very concerned about female hygiene and making sure that they had gone to have a pap smear in their personal. It was interesting with our ladies in that program. They really didn't understand conception or the elements of pregnancy. It was a big need for women to understand women's health issues. So I just put that out there for anyone who has more women's clients, you know, to look after their health. After 6 months, you can see, you know, we're still, the personal supports are increasing here. So the people who are still contacting us at 6 months are functioning people, because remember, a lot of them reconnected by 6 months. So family related, the basic needs of that profile in terms of, again, the housing would be in there and all the other things that I broke down. Their contacts with the non-connectors, a little bit, 37% initially. That's, again, because many of them come out with no place to go. We wanted to set up a system where we had a place to go, because that risk factor increases significantly when there's no housing. The health issues, connecting them, again, same, a little more focused here. Family was a little higher. Personal development supports, getting them into a situation where they could learn more about themselves and their skills. And then these are the outcomes resulting from the TA efforts here. So where did they go? Basic needs, identification, 4%, transportation. I'm not sure if all the people that are in the community now have all the necessary. I can think of some people that I'm in contact with don't have a birth certificate, have lost, their wallets were stolen. So they lost all their IDs. Housing, and of course the majority was in, I've forgotten the breakdown now between Edmonton, greater Edmonton area and external, because when we go out, then they usually end up in a family home. Some form of treatment, primarily that would be addictions, being referred to Henwood or Poundmaker, but of course our problem is there are waiting lists, and we would try and set that up before they left. Recreation, one of our focuses while they were in the fort was physical exercise every day. We originally wanted to run a very heavy regime, because there's good research to say that if you do a systematic pattern of exercising, you can affect the brain with people who have cognitive impairments. So that research, but you've got to do it on a systematic way and a high intensity. And unfortunately, we couldn't set that up. We did have an exercise physiologist who was part of our team, and primarily most of them were within the normal range, because you know, a lot of guys there, they pump weights, and we'd say, that's great, but what about the legs here? And we had volleyball and exercise, because when they left, we wanted them to go to recreation programs in the community. That's a natural place to meet new people. It's a place that every community has. Many played hockey or had sports where they can go out and participate in the mainstream, not a special program. And this is about using the resources that are in the community. But they need that ability sometimes to get there. Transportation is a key element. So we wanted to habit train while they were in the program, doing physical exercise, the reasons why it's important, but also putting them in the pattern. This is a whole group of people that learn by demonstration, and the more they do it and they practice 10,000 hours, the greater, I think, confidence you can put in changing some of their patterns. Because we can't rely only on mental processes. So getting involved, feeling the results, looking better, meeting new people, there's a lot of secondary things out there. Financial outcomes. AISH, not reported, working. Now, I'm really suspect about the working, because I'm sure the pattern is like I've described, that many are able to get a job, but if you were to track them, you will find that it's maybe 2 days, 3 days, maybe 6 months. 6 months usually means that they're maybe firefighting or somewhere where they're in seclusive environments where there's a containment and some sort of built-in support by virtue of the job. And then you'll get this pattern of losing the job. And what you have to be very careful if you're writing, if you're reading social supports or reports, well, he had a job, and if you look at the pattern, and maybe it's more recent, it looks like there's an employment history. You really have to look carefully at that employment, because you'll really find that it's not a sustained employment pattern. Get it, lose it, get it, lose it. So when you're thinking about AISH, and then you look at the conditions, the majority of them are candidates for AISH. And then put them into a productivity role. Help them select from their interest, identify in the community the things that they would like to do. I think we do a much better job with our PDD clients, particularly those that are in residential supports and group homes where there is an organized program. That model, way back when, what used to be called services for the handicapped, and that social integration has patterns and programming that really fit a large proportion of the needs of adults with FASD. So SFI, 70% of them. Because if not, SFI and some support, homeless. And then we end up with another cycle of friends. But you can see, if there wasn't someone there guiding them, and now the research is saying, well, you know, these transition workers or navigators are really not as effective in some areas. And so we have to understand when are they effective and when they aren't. Housing status, friend, family. So this family, again, is a little looking for the word here, a little deceiving. Might be couch surfing, and it might be, you know, primary family first, or a sister, or a relative for a while, but it's not stable housing. And often the family isn't in a position to provide the other supports for them to go out and find independent living. So these are the ones that we've used. You can see where there's the risk factors here. So everyone, it's absolutely essential. Stable housing or stable residential support. A model that I'm involved in too is with the house next door, which is mental health. And we've been running transition housing and sort of a residential support. It isn't treatment in the community for close to 30 years, if not longer. And in that setting, they get the supports. And I think there's something to be learned from that model for some of these clients, because we have people that go out from the house next door into apartments. We continue to connect with them and monitor them. And those that do go out come back. I use that phrase, you dated me, ET, call home. They need to have a place to call that is always going to be there. And the house next door is always there. One of the challenges when you have different support workers and people change, you need consistency. And establishing a relationship early on and persisting with it is one of the key indicators of a more productive lifestyle in the community. Advocacies, pretty close, sort of. In the advocacy area, you know, you're out there lobbying for them, trying to get access to the service. We wanted in some cases to take the group in the correction setting and fast track them for their SFI and their AISH. So there was one worker who knew this group, and we could do that because we, again, put them at risk, and we talk about the costs. If they go, have to make the application, and if they're on their own, we know that they may not stay, and there's just so many inherent problems. So we were, again, looking at risks and trying to determine how we can shorten up the process and reduce the risks. Spent in the community after reconnecting. So here's the percentage of how it happened. You can see 1 to 14%, 10% spent 1 to 14 days in the community before they reconnected. This all has to do with reconnecting with the justice system. And as we go around, you look here. So here's our greatest group, 29% here on the up to 300 days. And then a smaller group, again, they would be those people that probably had better education, and we're still talking about, we only had 5 people out of the 49 or the 50 who did not have an FASD diagnosis. So we're talking primarily about people with FASD, and I think this reflects the spectrum in the functions level. So, recommendations to the community, and part of these were coming out of the summative findings from our community partner, as I said, was Bosco Holmes, we had 2 transitional advocates in this pattern, and they had a caseload. And our program was set up is that we did 4 cohorts, and each program was approximately 10 to 12 weeks. So you were admitted, and we did the model of the diagnosis concurrently, which is being modeled out in the community now. With some of the children's service, you blitz all the assessments on one day. What we were finding with the justice we bring people in, we'll do the neuropsych testing, we'll do the OT testing, some of the other activities will go on in the community. Then when we come together for the formulation, all of us meet around the table. So this can be a period of weeks over time that we're doing this. And it seems to work much better. It's the challenge with adults often, there is no family member there to help them receive the findings and the master plan. Everybody went off with a very short version of their own findings and the recommendations for the community. We were very sensitive about that and being concerned that a report would get lost, but we felt obligated as the information. So it also said their personal copy on it, so that there wouldn't be any perceived breach of confidentiality in that. So there are some other considerations when you're working in the community and looking at the way the guidelines are set up. And this is what a lot of research in the process is going on now about the formulation of guidelines and procedures for adults' assessment to make the diagnosis. So, supported and supervised or residential support, and I already mentioned the house next door. On their own, why did they lose their housing? They might have had friends come in who they connected with once. We had 1 or 2 who were met as they left the fort by a group of friends, and they immediately went to celebrate, and things were downhill from there. So we were trying to set it up that community support was going to assist them from the moment they were released, actually be there when they were released, and take them to already acquired housing. So but we weren't able to do it. The housing considerations were, they were just getting ready. This is 2010. They were just getting some of the housing initiatives really organized. But be that as it is, going to housing, even with someone on site, they're not on site always attending to the individual. And that's why that residential support model of the house next door, there are workers in the house around the clock, 24 hours. And so they are making sure that people get to their appointments, their medications are dispensed there. But as I said, it's not a treatment. They organize programs. There's a constructive use of the day, and people are encouraged and supported to engage. So, safe and sober housing, difficult to access, especially in areas outside the inner city. And that was another major objective, taking them out of the high-risk zone. And both transitional, that word is not being used now, but housing where they need a time to be able to reflect with someone in the community about all of those value things that I said about who am I and what's important to me, and using that to program plan. I didn't see in the data there, most of ours had served their sentence, so they wouldn't have probation. and they wouldn't be connecting to probation officers. And of course, the federal system, we certainly want to work with John Howard and the Elizabeth Fry setups for people in who have still got conditions to fulfill. And high tolerance levels. Now, there are quite a few residential supports in the inner city, and they have really expanded, and I have students that work down there as well. Or one of my colleagues is involved with the Boyle Street Co-op. But it's getting supports outside of that key area. So, before release, and for people that are in the community, they're coming to you. They probably have housing. I'm not sure how many people would have anyone who is homeless, but our group now may not appear homeless because they're traveling. They move around. They get on a bus and they go visit a friend in another community, and then they stay there. But for all intents and purposes, they do not have a permanent residence. And it's very hard to do anything supportive in that kind of interaction. And then you lose their numbers. Addictions programs, so the questions you want to spend a little time on is about their substance abuse current use, and the patterns, and developing a strategy that's going to support them. And part of that is that social networking that I said. They tend to hang out with people who are using either drugs or alcohol, either in the house that they're staying in or in the contacts that they're reconnecting with. And it's similar now with some of the people that we're seeing. That we are testing people in the justice, but we're also seeing people being referred from the community because their social support worker has found that their job patterns and their living patterns are very erratic. And so do they have fetal alcohol spectrum disorder or not? And then trying to find, and I can say many of them are in the rural White Court, Barhead area where we are, and again, housing there. Those supports are hard, and we're coming up with some strategies to maybe set up a relationship with a community-based group where we could have so many slots. Some of the models that we wanted to use in the housing was, rather than the individual rent the space, a program. Because what was happening in one of the agencies, we would set it up, we would pay the money, our client would do something and they'd get kicked out. So there's a vacancy. So then we would try and put another client in there, and we would have to pay the money again, new client, new renter. So why not rent the room and have it as part of the contract, so that if perhaps it may not be somebody evicted, maybe we found a job somewhere or there's a community support out of the city, then we could use that room for someone else. Much more cost effective. We got to think in much more creative ways of having that. And that's getting into not as formal as a facility, but we could have a facility or a support within a facility. Anyway, I really would like to see the house next door model, because in the case there with mental health, we're able to support them and we don't have the problems with addictions too. So that's, again, it's the addictions, the substance abuse that usually creates the first event that then becomes a chain reaction. So many of these things, long-term, there are standard procedures out there. And I'm not sure that, we have to get into human rights and considering with random testing or so. But the residential supports, I think there is an older model too. There used to be a model called the therapeutic community. And it was used in mental health, and it is a residential support. But the difference between a residential support program and a therapeutic community, very, very simply, is the people in the residential program are part of the decision making. They're running their own community. So it becomes a training environment, and decision making and patterns are all in. It's an old model that was in the 70s. I think it's time for us to kind of look at it again when we're looking at trying to change some of the habits. It takes high repetition, large support, consistency to change habits. With the children, we know that they respond to structure, they respond to repetition, and this is where the brain plasticity research is maybe going to give us a lot of options. When you think about the brain that I described for you with the adults we're seeing, plasticity strategies, which are often talked about with people with stroke, they're not having multiple assaults, usually if they don't have another stroke, but they haven't got that addictions layer overall, and they're usually not going to be in a risk situation where somebody's going to hit them on the head with a baseball bat. So we have to be very careful as we pick up these words and try to apply them in these particular situations. But addictions has to be a priority, and models that work for this populations. It is the thing that gets them in jail, creates the family disruptions and of the support systems that are there, and can be life-threatening themselves. Urban life skills, I've said I'm considering, buying the bread. And the way you work with these people is you do it. You don't talk about it. You don't use a workbook. You go to the grocery store and you go through the pattern. And you do it numerous times. And then it's like chaining. You move yourself about and to find the level at which they can do independently. And then expect that level. And then you have to repeat it. Banking now, of course, most people have some kind of plastic if you're in the community. That's a real problem with the banks. I don't know what we can do. I have one client, he had a $500 limit on his bank card. So he would get his check, they would deduct the $500 because he went over, then he would have his money, and then he would be over the limit again. So he was always coming out. So I finally had to go to the bank with the client, and we lowered the limit so that we weren't in this catch-22 of constantly being behind. And some of the things that we're doing now are making recommendations. If we do have somebody who is on assistance and getting money, that the rent and some of these things with be automatically deducted at source. You have to be realistic if they're going to be able to deal with all of the demands in the community, to be able to structure some of those that can be done mechanically, and banking is one of them. So you take off the costs at the beginning. Some people had reparations to be paid to others, whatever the agreement is, and then they're left with their discretionary money for groceries and others. And because of the addictions, every one of them are at risk from taking the money as all in that bank and going out and partying. And again, I'm seeing a particular group of people, and that doesn't generalize to all. But for the purposes of even decision-making or impulsivity, shopping, buying more things than you really need at the moment. So there is that combination between how we understand about impulsivity, about the judgment and the planning, and money management, a key element. So they need that early training that we assume we get in our developmental period. Many of our clients, if they haven't been in positive foster home environments and had a nurturing group of people around them, they've never developed those skills. And as I said, and it's also a matter of numeracy. On the neuropsych testing, all of the numeracy tests are very, very low. Any of the math skills. And they'll inevitably say, well, I wasn't good in math in school. And when you look at their school patterns, one of the things that I learned just in answering that is about health records. I, in my naivety, being in the health system and being a worker for almost 50 years, did not really understand that they destroy health records. That health records aren't in some grand repository somewhere in Alberta. That regional and even large ones, discard them. If you haven't been in their place for a period of time, now things maybe are changing a bit as we move to some of the systems approach and electronic record, but I can tell you that, I can't remember the percentage, but it was maybe 30% that we found the health records. Even when we know where they were born and where they were, the health records did not exist. And my goodness, you know, then you can't go back and look, how well were they? Some of them were looking at the history. What kind of a baby? Were they a failure to thrive baby? Were they in the hospital? Did they have asthma? Was there a respiratory thing? All of the things, the social determinants of health, affect their ability to grow and develop on a more normal continuum. And not there. That was a huge surprise to me. I thought we'd have to track them down, but I thought they existed somewhere. And of course, as we all know, accessing, even with consents and all of those things, it was still a problem. So where do I go to find? Who do I talk to? Accessing community services. This is where the translation from the support people in the community and the buddy system. You know, we don't have to have formal programs. Using the local resources, there's a colleague of mine working with mentally challenged mothers. They've been working around the Provident. Some may know about him. They're meeting together for coffee. We originally wanted to have a coffee clutch inside the fort, but they wouldn't let us have it. Sort of a place where we could have coffee time and fellas could come. But what you have to understand about that system is people don't want to be identified because information is a commodity in corrective systems. Information's worth something. And so people don't want to be in, but a place to go. That's why in the mental health system for years and years we would have, you know, large congregations at donut shops and other places. There were no places for them to go and to be normal. So we need to have those social nodes in our community that allows them to gather, to meet other people. And they don't know how to, they can tell you, if I want to take the bus, I can call a number or to look at the schedule. But I know at times if you don't ask them what's a bus schedule for them, they wouldn't think about doing that if they were looking to get downtown. So there's just some assumptions we make about understanding that one has to go back and check it out. So how would you do that? So you might ask those questions. So then you're involved in problem solving with the individual. It's very important that as they interact with all of us, that through that process they are learning. And learning, again, has to be repetitious with this group. One time does not put it in place. How do I get a home? That's the question there. Most of them were very concerned, and I'm sure many of them are, you know, everybody wants a place of their own where their stuff is. And some of them are separated from family. Our men, you know, they want to see their children. And being able to get that normalcy in their activities and their roles is really very important. And of course, there are problems with our group because sometimes there were restraining orders. So it's not easy. But we have to work with the environment. We're spending a lot of time working with the individual. It's not just advocacy. We need to put our energies in problem solving the virtual environments that people live in, the communities that they stay in, and making them accessible and using the basic health programs that are there to go and to participate. Whoops, went the wrong way. Urban life skills. Health treatment and monitoring. They have health conditions. When was the last time they went to the dentist? They can have a dental infection which is going to be systemic and affect them all. Some of them, not as many had Hep C as we thought maybe they might, because we didn't have that many who were needle users. Medications, of course, is a major problem in the system now, because medications can be traded for other things, and there needs to be cautious thinking, and that's where the supervision in a residential support place with him, that those pills aren't then on the street. Treatments for underlying disorders, mental health. When we've got mental health and addiction, these are what we call complex cases. Specialists in not as many situations. There were some who had underlying health issues that hadn't been looked at, heart conditions and other things. But again, we weren't able to do that, and that's where the community would be. So, the front end, the early intervention, the screening, an intensive, we want to invert that pyramid. We want a broad base of services on the bottom, and then only be strategic in going to a specialist or somewhere after there has been all the conservative ones. But our clients in this group are challenging. And so, the rest of us that using primary health care or going to some of the clinics, they know about Mediclinics, and they go and they have some of the relationships with them. And if they've been long enough in a community, or there's family there. Counseling for mental health, and it has to be a special kind of counseling. There's a real concern in some areas where the communities are tight-knit about using local resources because everybody will know. So they'd rather, at least our clients, would go to a counselor who not really connected with their community in a sense, or their ethnic group. And again, practical. Exploration, we ran, there is a psychologist that has been working in the fort for a number of years, and he has run a group, and we incorporated it as part of our program that looks at shame and abuse and the exploration of that. And that is a major underlying issue, as many of them have been physically and sexually abused at young ages. Imaging, well, a good clinician can detect things. We don't need all of the MRIs and the others and those things unless we're being very explicit about some issues and it's going to make a difference. I heard a presentation yesterday on the clinical networks, scientific clinical networks in Alberta, and we're a leader in this, and it's really exciting. But again, their model is this broad-based, conservative interventions at the front end, looking at early intervention and only going to specialists as the last resort. As the story was related, a surgeon said, well, if you send me somebody, I'm going to cut them. I mean, that's my job. So you want to go through all those other things. Conservative, in this case, it was, we're talking about musculoskeletal. So you want physical therapists and occupational therapists doing the assessments and the treatments. and getting in there early so surgery isn't needed. That's another issue. So it's about saving money in the system, but sometimes we do that because we don't know what else to do, and we feel like we have to do something. But there's such waiting lines. So we have a lot of community resources that I think we can reconfigure and rejig, not only for this group, they would also help our mental health clients. Training support. For some of them are eligible to have upgrading, and so they need in the classroom setting, the very few that would do that, oral, slow, clear, rather than written examinations, access to tutors and study strategies. These are learning strategies that are pretty common across. We do some of this in universities for students with learning disability. Gym attendance, improve social network and health. And as I said, if you can get someone to undertake a systematic regime with a coach, the research is out there and it's pretty clear. That's why all of us who are getting a little older are being told to do physical education or physical activity at least for 30 minutes a day. It does affect your cognitive strategy, and we know that these people have cognitive impairments, and that's really why we wanted to get a regime and do the pre and the post tests. But unfortunately, the environment, in the way that the system is set up, in our project, we were a guest in somebody else's house, you know, and we have to abide by their rules. Artistic expression, creative drawings. Drawings and our doodling is a great way to facilitate communication. And verbal communication, getting their thoughts together, being able to express what they want is a challenge for some of the people in the middle and the low impairment area. So drawings are a way for you to introduce or see what is going. It's projection in a way. Community programs global. So using the community as it is, but taking a look at it and doing some restructuring. Here's my productivity word. Few are competitively employed. And I think we do them a disservice, we do the employer a disservice, and the system when we look at getting them a job, when really, if you look more carefully at it, and you can always get some help with that, that they've never been able to sustain a job. So they need demonstrations. They are the classic old-style apprentice learner. This is a nail, this is a hammer, this is what you do. Now I want you to do this 20 times. As you know, the more formal apprentice programs now have classroom settings, and some of the jobs in the higher ends, in the areas where we're looking to find more workers, need apprentice training. And some of our clients got in, and then they got out. Learn one stage of a task at a time and repeat it. Visual cues to remind. And there's a lot of good literature with the children, using colors and codes and symbols. Same with adults here. Because in a way, the people that we saw, and probably the people who are coming into your support, have not had the benefit of what we might call the normal developmental education that the environment and the school system gives them, because many have been erratic in attendance at school. They've had attention deficit or thought to have that. They were disruptive in the classroom. So they didn't get all of that sitting at attention because they can't. And there's been many wonderful presentations at the conferences in Vancouver talking about that. But at the adult level, you have to remember that they are missing those things. Thank you for coming. Check response performance. So you've got to continually, it sounds like I am advocating, and I guess in a way, a much more intense relationship between the support workers and the individuals in the community. It doesn't always have to be face-to-face. We can use the technology, but it is the prompting and the reminder. One of the questions at ILS is, you've got medication to take, how will you remember it? Well, the majority say, if I've got a phone, I'll program it in my phone. They forget to do that. And when they get that get the stimulus, they may not react to it. So that intensity of reminding, supporting, and going through the process together is really the key element. That's that 10,000 hours. Routine tasks, not complex duties that change rapidly. So, as I said, if you just think about the next time you go into McDonald's and what that server who takes your order is going through. Now, if they're in the back, sometimes flipping the burgers, maybe that's not, and it's a low intent, but the person on the front end has to take your orders, have to plug it in, has to place it, has to then put it up wherever it gets prepared, come back to the front, take another one, then remember to go back and check the order, depending on the setup, some of the setups. So this, what we consider to be low-skill industry, has some really very complex tasks in there. Sequencing, this is where the problem is. The memory areas and the sequencing and the planning. I think one of the jobs that I hear that they're most able to do successfully is working in the night shift in some of the janitorial areas, because there's high repetition with the job to be done, there's supervision, and there's low distraction. So this area of job placement with Alberta Works is very important, but with our clients, there's a certain amount of job analysis that has to go on. That's going back to how this brain is thinking. Okay, this is my virtual community, which was designed with a view of looking at a systems approach. If we took an area, and one of the things you have to do is what I call an environmental scan in my business. So what are the resources out there? I didn't put in my 3C diagram, but we looked at the Edmonton area, and we identified all the services that were being there. And our thoughts were, how many of these will our clients use? Now, we connected a lot of them with the agency, but we don't know how long they use them or how long they sustain their work. And so I can print this and send it on a sheet, but it's community productivity. So is it work, paid or unpaid? So we've got a lot of internships. Now, most of these candidates wouldn't be useful. This is a more global. But the real area is developing productivity roles. And in some of our First Nations communities who are contained, there are a lot of things that have to be done, and some of our clients are doing that. They're helping with snow removal. They're doing some of the repairs in the community. That has to be systematized. So sort of that nexus, you know, that as we have here, you go to the job center, you pick up your job for the day. Community self-maintenance. Self-maintenance is a big term in our health network now, everybody being in charge and taking responsibility for their own health. Well, a little more challenging with this group. They need a lot of support to do that, and they should be encouraged to take on as much responsibility as they can. But they need that external reminder and support. Looking at this one, I can hardly see my own copy here. But then we have the environmental resources. These are all the things that would be in the community and programs where we can go and build in. And what we've got is this systems approach. So somewhere there is a nexus, a center, where there is maybe it's called the Community Support Center, who knows about what is available and what is there. And people are connected and monitored in it. And there is an expectation, and you probably should then at that point tie some of the reward system to that. And so if you are getting social support, there is the expectations. But it's much more systematized. And when I say virtual, it means that you could set this up a community within a community. And we have much more detail with that. But it's a classic, what we call community development model, where no new resources other than maybe the human resources are in there. And you are looking at what exists and exploiting the resources that are there, and then having the expectations. So, part 3. So this, I think, is where we can have some interchange I've given you an overview, and it's a little narrow because of the group connected with corrections. But as I say, they are who we see in the community as well. So my questions are, what do you need to support your efforts with the clients? And I think we have to think about this. This is heavy work, and I don't know what the caseloads are right now. You make a lot of phone calls. You try and track a lot of people, at least with our clientele in the project that we've got here. So there's a lot of time spent trying to connect. And that's daunting. All of us like to feel like we're being successful. So what do we do to support the efforts of the people who are trying to make a difference in the community? I've also done some research on compassion fatigue with health professionals. And it's not always the interaction with the issue with the client, someone dying. It's often the stressors in the environment that is the critical thing that's making the difference of a health professional can continue in their role and not succumb to the stress. I think that's very important as we fan out community models and community workers, that we be very, very sensitive to their particular health and support needs. So what are your clients? You're the best, what I heard over the last couple of weeks, who knows the client best? The client does. Now, sometimes it takes some very direct or indirect, I was going to say sneaky, interviewing techniques and picking up on the cues. They tell you forthcoming. It's not as if they're trying to hide you, but as I said, their expressive language, their ability to express themselves is sometimes limited. So you have to pick up on something they might have said and go with it and try and get more about it. So what are they saying about what's happening to them? They are your best resource of knowing about their current situation. There are a lot of resources out there. One of the things I saw was a diagram with a padlock on them. They're not accessible to our clients. The waiting lines are long. The paperwork is hard. If we invested in this community supports for fetal alcohol spectrum disorder people, some of the centralizing or the generic kinds of service where, you know, we are trying to share and learn from one another, and these webinars are wonderful. But I think the system itself can put into place the finances, the banking, the areas, hooking up with one of the big banks to say, we have a special needs population. Is there a way that we could structure this? So it sounds patronizing, but we know that the decision-making and the need for the external brain is part of this consideration in this population. So that's a positive thing. It's not making them more dependent. It's really being an asset to their independence. So from a community development, there's a lot of stuff out there, a lot of opportunities. People say, well, there's a lot of jobs that people want them. But not when you really understand how our clients are having to process information and interact with other people. In the McDonald's example that I'm giving about, you know, what we perceive to be a low demand job. I work with a young man who has Asperger's, master's degree. One of the things I do not give him is photocopying. Because the sequencing and the planning, and particularly the collating, is one of the skill sets he doesn't have. But you think, if it's just putting the information in now, but if you've used any of these new photocopiers, they are a challenge to all of us. So some of those things, social enterprise. I've got a project in my mind I would love to do. I saw a project in South Africa, and I would just wish I had the time to do it. Developing a kind of social enterprise has to do with looking at work and setting up a business-like model where the social good is part of it and it feeds itself. And I saw a brilliant one in South Africa that I would just love to do, and it's so OT-ish. But I don't have the time right now. So these individuals with complex challenges, what strengths of theirs is not being used? So strength-based models, in this particular situation, is really very critical because they have so many barriers. So anyone who's working from a medical perspective, no, you work with people's assets, and you make demands on them that is going to try and deal with where their limitations are so that you can move them up. But being able to give them the pride of the accomplishment is something I think we all understand. But, what is it that you would like to do? What are you interested in doing over time? What gave you the most happiness? And I can tell you the answer here always comes out predominantly my family and my children. So using family relationships and using children as an incentive to make changes in other areas, to stay sober, to keep a house, or to these elements are part of, it's not motivational interviewing, it's just understanding human nature. And I think that is the best thing. So your client is your best source of information, and then the next one is your element of environmental awareness. We're done. Is that a fire alarm?
I think that's this polygon. I think it's what? A polygon.
I think someone's trying to phone in.
Sorry?
Any questions? Any off-site questions?
Got a question here from Stacy in Pincher Creek.
Yes.
And her question is about negative social networks.
Yes.
She says, when you're talking about social network, does that include influences that may be negative to that person?
Yes.
Or would those negative influences have a separate category?
Well, I'm into considering, as an occupational therapist, we talk about occupations, which everybody talks about activity. And in the social networks, the negative social networks are those that are engaging in behaviors and or activities that are going to put our client at risk. So it's having your friends that are drinking, it's having your maybe gang members and those things. So we speak about social networks, and the collective is something we seek to be a part of. So if we don't want our clients involved in the negative social, we have to find them positive social networks that are going to support them. And so there are both psychological elements of that in terms of relationships that are abusive and negative, in that way negative impact on the client, and also there are the activities, the drugs and the crime connection. Is that clarification enough? But it's very interesting too. I'll give you an aside in case there's another question. I'm looking at some of the occupations that people do that are homeless. And, people talk about that being kind of a situation where they are engaging in negative occupations. They smoke, they drink. But there is, if you can bear with me, it serves a useful purpose of organizing their social network on the street. So it's a very complex kind of discussion. but it's who they hang out with. It's like, think about development kids. Any other questions?
Any other questions from you?
So 2 things I leave you with is understanding with more depth the complexity of the thinking, and that this often is someone who's had multiple brain impairments, possible, not just the FAS, the teenage drinking and the trauma. So their understanding of what you're telling them and what you're trying to get them to do may be even more challenging. And this element about the social networks and knowing the environment they live in, it's about knowing your resources very well. And as I'm saying here, advocacy for clients with FASD can never be enough. So thank you very much for inviting me. And you've put up my address. I'd certainly respond to any other questions or discussions.
Thanks, Sharon, for the great presentation. It was very informative, and I really appreciate the details of the learnings that you found. It really helps understand the depth and the level of awareness that we need when supporting folks with FASD. I think it also really affirms and confirms what caregivers have been telling us all along. So I think that's fabulous.
And that they need support.
Yeah. And understanding, and the question you raised near the end about ask the client to identify their barriers. Sometimes the barriers we identify aren't the same, so to get that good understanding.
True. Thank you.
So thank you very much. We have just a couple of more reminders. Evaluations will be emailed to you within the next 2 business days. And be sure to sign the attendance sheet so that you can get recognition for attending. Plus, we can send you the evaluation evaluation feedback. Like I said, your feedback is really, really important to our continuous improvement. Please join us for our next presentation on February 19th, when Dr. Jackie Pye and Dr. Carmen Rasmussen, both professors with the University of Alberta, will discuss technological innovations and interventions for individuals with FASD. Thanks, everybody. Thanks again, Sharon.
Thank you.